Chairman, before I start, I just want to underscore that the interoperability of electronic health records is a top priority for me. And I know reading in the press this morning that my bandwidth has been exhausted by finally achieving success on the sustainable growth rate formula. I just want to assure everyone that I have good minds working in my office on this issue of interoperability, and it will remain a top priority. I'm, of course, relieved that the Chairman Pitts and Chairman Upton, the ranking members, Pallone and Green, also have made a similar commitment to this issue. And it is my sincere hope to have this issue advanced by having this markup, but to have this issue advanced by the time we get this draft to markup. So I've talked in the past about my own frustrations with electronic health records, and here we are years later, and I'm still hearing from doctors that electronic health records fail to deliver on the promise. A patient seen in the emergency room with chest pain follows up with their cardiologist. That doctor should be able to review the patient's health information recorded by the hospital without the patient having to request that it be faxed, without the secondary doctor having to pay an exorbitant fee, without having to agree to use the same electronic health record vendor as the hospital. And yet many times that's the way our world is working, and it's frustrating for doctors and it's bad for patients. Doctors and hospitals have invested time and money to make this switch to electronic health records. And we, in this committee, under the stimulus bill and to some degree under the Affordable Care Act, have invested $28 billion taxpayer dollars to support this transition. Developments in the technology have far outpaced the capabilities of the systems. This is not a tech problem. This is a bureaucracy problem, and we can fix it. So, Dr. Hudson, let me ask you, if people were able to seamlessly share their health information in electronic form with the National Institute of Health, would it improve researchers' ability to identify patterns in diseases?
Yes.
Thank you. Thank you for being succinct. Another issue, and I'm very committed to protecting First Amendment rights of clinicians to share and receive truthful medical information. The current draft, in my opinion, must do much more in this area. So, Dr. Woodcock, given that approximately half of the medicines prescribed to treat cancer patients in oncology centers are used by physicians off-label, and over 60% of pediatric prescriptions are off-label, wouldn't it benefit patients if the manufacturers of these medicines could provide physicians and payers with the most up-to-date, truthful, non-misleading information about drugs with no delay?
Well, there are multiple pathways, of course, that clinicians can get information from manufacturers. They can talk to them. There's scientific meetings, there are publications, and so forth. And there are downsides to establishing essentially a market for a drug before it has been tested for a given indication. Now, for economic purposes, for payers, formulary committees, we understand that a free flow of information is needed, and we look forward to working.
Right. There are First Amendment considerations here, but it seems like the FDA should allow a company to distribute to a physician the peer-reviewed New England Journal of Medicine article, for example, that may have been important in getting this product approved in the first place. You know, before my time has expired, I really do appreciate, Mr. Chairman, you holding this hearing today, and I appreciate our witnesses being here, and I know it is a long hearing, and to some degree we're all somewhat long-winded and drawn out. On the issue of precision medicine, on the issue of personalized medicine, I do worry that some of the things that have happened recently, within the last year and a half, have kind of put the brakes on what should be happening in that space. And specifically, I'm referring to genomic information, which should. Why is my genomic information that 23andMe has, why is it locked up, and why is it locked away from me now? Why can only I get ancestral information from 23andMe? It's great to know my mother was descended from Jesse James. I always suspected that, but actually it would be more useful if I knew whether or not I was at risk for multiple sclerosis, for example. And on the concept of precision medicine, and we've dealt with laboratory developed tests before, the ability of a doctor to get a more precise diagnosis sometimes hinges upon getting those laboratory developed tests and not impeding their development. And then finally, the whole concept of medical apps. It is one that has exploded since Really, we've begun having some of these hearings, and I very much look forward to the day where medical apps, laboratory-developed tests, and consumer-directed genomic information can help direct that precision medicine. Mr. Chairman, I'll yield back.